All right. Well, welcome to the second episode of the Peptide Pulse. Thank you so much for joining us tonight. I'm super excited to be doing this again after a really wonderful first episode last week. And in that episode, we just kind of laid the foundation for talking about peptides. I had some wonderful guests, and they shared their experience of personal use of peptides, plus their experience in their clinical practice. And tonight, I have two other wonderful guests with me. Lori Fitzgibbons and Kimberly Brown, both of whom are my colleagues and friends. They are board certified PAs and they are just wonderful. So I can't wait to hear from them. And today we're going to be talking about GLP-1s and how they are more than just weight loss. The majority of what people understand about GLP-1s is that their only indications are for type 2 diabetes, obstructive sleep apnea with type 2 diabetes, chronic kidney disease with type 2 diabetes, and of course, weight loss over a certain elevated BMI. However, what we're finding is that, especially in the integrative and functional medicine communities, we're using these medications for off-label reasons to help in other ways and really help fill the gap. This is the future of medicine. And tonight we're going to hear from these lovely guests and see how they're bridging the gap using peptides in their clinical practice. The thing is this is really for anyone. So whether you're a clinician like we are, whether you're someone who is in allied health and just interested in how peptides might help your area of medicine or your area of nursing or other specialty, or if you're someone who's just interested in health, there is an answer for you here tonight. And I'm super excited to be able to talk to you more about that. So one of the things that I've noticed throughout my career of almost 20 years in medicine is that when you're treating patients, you only have a certain limited bandwidth of therapeutic options. And now what we're finding is peptides are expanding those options. And specifically with GLP-1s, we know now with a lot of the research that's coming out that we can use them for way more than weight loss. And that's one of the things that we're going to talk about tonight is some of the research, some of the findings, and we'll just get right into that. So I would love to bring Lori Fitzgibbons in to begin talking and sharing her experience with peptides, how it's working in her clinical practice, and just her take on what's changing and how it's going.
Hi, can you hear me okay? Perfect. Okay. So I am Lori, and I've been a PA for about 20 years now, mostly in the family practice space, but I have a really big passion for preventative medicine, and I like to think about things a little bit outside the box. So traditional medicine, people come in, we diagnose them with problems, blood pressure, diabetes, obesity, but what I like to think about, I like to think more of the whole entire picture. I don't think it necessarily suits a lot of people to diagnose one problem and have the one medication that fits it, because a lot of these things are intertwined together. The weight is intermingled with the cardiac health. The blood sugar problems are intermingled with the weight. And to just pick one of them at a time and do a specific medication for that, just doesn't look at the entire picture. So we actually haven't had a lot of medicines until recently that treated more the entire picture. And the GLPs do seem to be really good at that. They've been out for about 20 years now. They're making better versions of them. In the last 6 months, or actually year, I've been working in a functional weight loss clinic, and I love having the option of the GLPs for weight loss. But what has surprised me is how much better people feel on these medications. It's not just about losing the weight. So when we first see people, they're coming to see us because of the weight. But generally, people will have joint pain. Joint pain is especially common in our overweight population, and it's not just I need a knee replacement joint pain. It can be swelling, it can be edema. People come in, they're just kind of puffy. You can even see it in their face that they're just inflamed and they're swollen. We do a more in-depth panel in my practice. So we don't just do a blood count and a metabolic panel. We actually look at inflammatory markers. The one we like to use the most is a high sensitivity, CRP. And I find when we first see people, it's pretty common that that can be elevated. We see that elevated with many different types of inflammation. Can be joint inflammation, it could be rheumatology type conditions, that can be elevated when people are having allergies. And I found as we treat people, that number goes down considerably and they just tend to be less achy and they tend to just overall feel better. First visit we do this scale where we say, how are you sleeping? How are you moving? You feel good? Do these joints good? And I find that people will come in, they'll be all on the everything is kind of crap side. And as we're treating people, it moves over. And when we're finding the right mix, everything starts to go to zero. There's always some fine tuning. There's always some things we can adjust. But as we find those things that we adjust, it does tend to go to zero. Now, the GLP-1s are our major tool that we use for that. One of the reasons, and it works in several different ways, but the one I like to emphasize is how it seems to help with insulin resistance. The way I describe insulin and glucose and the way our body works with that, I describe glucose as kind of a scratchy type things. And if you're thinking of sugar, it just is this scratchy kind of substance. So when your glucose level goes up, I just think about it kind of scratching at your blood vessels, scratching the body, and just causing inflammation. When that glucose goes up, sometimes your insulin will shoot up and that gets high and then it drops pretty fast if you're not eating enough protein or eating enough food to balance it out. That drop makes people feel really crummy, makes you feel really tired, makes you feel really achy, and wakes you up from sleep. These GLPs seem to help with that roller coaster feeling, not just by making people not hungry. That's a very common misconception. It's not that we give you a GLP, you stop eating, and that's why you're losing weight. We give you a GLP to help with this inflammation. We give it to you to help balance those insulin levels and those glucose levels. And by doing that, it seems to really just help people feel better. So I'm also into the microdosing and more the preventative health side. It does look like we're starting to get some good research, even on things like Alzheimer's, using it around perimenopause, using it, post-viral type things, all these situations where people are just inflamed. This medication does seem to help calm that down. So is it time to turn it over? Or do
That
I
would
have
be
more
fine.
time?
You can, I mean, if you want to share more, that would be fine. It's so fascinating to hear about the diverse applications that you're seeing, just even in that integrative weight loss practice, because it's not just weight loss, even though you are using, I mean, the patients are coming to you directly for weight loss. There's so much other stuff that's really tangled in that web of trying to sort out what is underneath the cause, one, for weight loss, and two, for the inflammation. So how wonderful. So I'd love to hear more.
Yes, and that is one of the things I get so excited about is actually seeing those inflammatory markers go down. I find it to be really fascinating and seeing how much better people feel as those markers go down. Same type of thing with the thyroid. A lot of these things that we see people with, and I find it to be all the labs are normal and we don't know what's wrong with you type feeling. When you're going to your primary care and you just don't feel good, but maybe you can't describe exactly why. Yes, you're tired. Yes, you're achy. The weight won't come off. You're doing all the things. You're eating less calories, which is not necessarily, I don't think, the best way to lose weight, but that's what we used to tell people is eat less, move more. There are healthier ways to do that work better. If you do restrict too much, it actually increases your cortisol, which makes your inflammation go back up and makes you feel even more rotten and you store more around your middle. So I like seeing that these medicines seem to be helping with a very large constellation of problems that are in the inflammation area. It's joint pain, it's thyroid, the weight starts to come off around the middle when people are feeling healthier. That insulin resistance goes down. We actually check fasting insulin numbers, and we like to keep below 10, and that starts to look quite a bit better. I'm very interested, especially in the microdosing on the longevity side, and just that feeling of I've tried all these things and I still don't feel good and I don't know what my next step is. I find this medicine to be really fascinating in that area and seems to really make a big difference.
That's awesome. Thank you so much, Lori. And I want to ask, just because the clinicians may know, but for those people who are not in medicine, would you run down what you know if people are inflamed that we have the option to use that one isn't going to cause an ulcer, two isn't going to alter renal function, and three is something that they can be on long term?
There's not a lot. There are some supplements that might can calm things down a little bit, but they don't work very well. So normally, if you're having joint pain and things are slowing you down, the typical prescription answer is going to be an NSAID. So NSAIDs are things like Motrin, well, Motrin, ibuprofen, they're saying naproxen, that class of medication. We've got meloxicam and some of those as well. And if they're keeping you moving, they are probably worth it. But we do see some increased cardiac risk with some of those medications. We also see kidney problems with this medication, and the GI bleeds can be a really big problem. So they are not without side effects. There are some more interesting kind of supplement things that people try, even things like turmeric, which can be really pretty common. But some people actually react in the opposite way to turmeric, and they get more inflamed. Turmeric is one of the things we look at on our food sensitivity panel, and sometimes that can be pretty high. Sometimes we look at things like omega-3s, but none of those have great research to say it really does decrease inflammation. But sometimes we can pick and choose some of those things and give those a try. But I can't think of anything off the top of my head that overall body inflammation has made that big of a difference. Sometimes I'll try berberine, sometimes boswellia, but really those are kind of trial and error, and it doesn't. They might work for some people, but not for everyone.
Thanks so much, Lori. I really appreciate that. And especially understanding that we have these limitations. And it's really about how can we fill this gap where if someone has symptoms, we don't have any other options that really fit the symptomatic profile and are able to be used safely. And someone else who would really love to speak about this, because this is something that's part and parcel of her practice, is Kimberly Brown. So, Kimberly, I'd love to hear your take on especially the inflammation side from your specialty and what you found to be really helpful when either the options aren't so great or the options haven't worked.
Yeah, so I am a physician assistant in hand and upper extremity. So in orthopedics, it's a little bit odd to kind of have another option for patients right now. And it's awesome because typically what we see kind of the treatment plan in more than just hand and upper extremity orthopedics, but really for all of orthopedics is kind of this stepwise fashion of the initial treatments are going to be your NSAID medications and therapy. Then if those don't work, then you're looking at more corticosteroid injections. If that doesn't work, then you're looking at surgery. And it, of course, can differ, but that's kind of the general pattern. If you see an orthopedist, that's what we're going to talk about. So, like we've kind of touched on, we have plenty of patients who say, well, hey, I can't take an NSAID. So then that knocks that option down. So then when you're talking about, okay, well, what medications can we use to help decrease inflammation in these patients, whether it's from arthritis, a sprain, a trigger finger, carpal tunnel, really any diagnosis where inflammation is kind of the root point of what's going on, then you're stuck with Tylenol, which right now I don't feel like people are jumping up and down about taking, or maybe a Medrol dose pack, which is another orthopedic favorite. But the issue with a Medrol dose pack and being an oral steroid is it's short term. So people will feel great for the 6 days that they're on it. And then you're kind of back to square one. So then what can you do to manage the inflammation? And that's where we kind of have that gap and where this can fill that. So working in hand specifically, we see a lot of patients who come in and maybe they've got just a vague complaint. They say, my hands are just stiff. They're just achy. They don't get numb and tingly, but they're just, a few times the joints will get swollen and you're kind of scratching your head. X-rays look totally normal, but you can tell these patients are really struggling. Even MRIs can look normal. And so a lot of times, and there's been research that does show that patients with rheumatologic conditions like psoriatic arthritis, rheumatoid arthritis, lupus, they show up in a hand clinic years before they get a diagnosis. And so even with those early stages, all of your lab markers for these inflammatory conditions are all normal. So you can send them to a rheumatologist and the rheumatologist says, I don't know, looks like you're fine. So then you're back to, okay, well, what oral medications can we do? We can send you to hand therapy. Or now we have the option of talking to patients about, okay, well, let's get creative. What do you think about a GLP-1? And how can that help? And so the way that we're starting to see research-wise that this can be helpful is that it decreases inflammatory markers. So with different inflammatory pathways. So, and especially you'll see it in patients who do have a degree of obesity that is impacting their health and their condition. But excess adipose tissue is going to promote chronic inflammation by releasing some inflammatory factors in our body. So even if it's not clinically significant enough to show up on lab work, you're still presenting with these subtle kind of signs and symptoms of this overall inflammation. And like what Lori was saying about just being, patients will genuinely look puffy and they just feel bad everywhere. And so giving them an option that works systemically, but isn't harmful like other oral options that we have now is an awesome way that we can create an extra avenue than what we have. Especially with those patients too, if it's one joint that hurts, easy peasy, cortisone injection, it'll calm it down. And there are risks with doing that because you don't want to do too many, but it's when everything hurts, you can't use that patient like a pincushion. So this gives them an option. And I've told patients, run it by a rheumatologist, make sure that there's nothing else that we need to add in. Does it need to be an adjunct to a DMARD if you do have a diagnosable rheumatologic condition going on? And so that's more of your biologic medication. Other areas where I've seen it help are in, so that's usually going to be more of our older patients. I would say probably between 40 and 60 is the age range that I see that clinical picture. On the flip side, though, I've started seeing a lot more young patients with like carpal tunnel, and it's so easy to say, oh, well, okay, you've got carpal tunnel. Let's do bracing, let's do an injection, let's do surgery, and that's going to be your typical thing. But if you just take a little extra time to kind of talk to the patient a bit more about what's going on, then you might find, oh, well, they have a diagnosed condition of polycystic ovarian syndrome, and they really have trouble kind of managing their insulin resistance. And maybe those hormonal changes are why we're seeing carpal tunnel. And if we can fix that, we don't need to do surgery. So then you have the patient explore that option and see if you can fix the problem from the root versus just fixing part of the whole picture. And so those are areas where I've seen it the most. And I think it's going to be awesome. I think the biggest thing now is separating the weight loss aspect of it in terms of how that affects joint health and just having independent kind of knowledge and research that shows the like chondroprotective, so cartilage protecting features that we can see. So more in use of like just good old wear and tear osteoarthritis.
Well, thank you so much, Kimberly. It's so wonderful to hear how you are just seeing the spectrum from those young patients to patients who are older. I actually, you know this, but I used to, when I first started, I started out in pediatric orthopedics and sports med, and I was seeing patients up into their 40s who had long-term issues. And this was almost 20 years ago, and we were so limited in what we could do. But to have another option is just amazing. But it's interesting that you say that research specifically, that we need more research specifically in something showing the GLP-1 is working, not just because of the weight loss. And there are actually some interesting studies. There was one particular study, I actually wrote it down. It was in the Journal of Headache and Pain in 2024, and it showed that GLP-1s, it was a lit review, and it showed that GLP-1s have analgesic effects. And they modulate pain sensitivity and inflammatory and neuropathic pain. So it's really amazing to think about, wait a second, we have much broader applications. So for those patients who have RA, or they have lupus, they have an autoimmune-like condition, or an autoimmune, diagnosed autoimmune condition, they are really finding this to be a wonderful adjunct. Now, I'm hearing a lot of feedback from people saying rheumatology isn't necessarily prescribing them, but they are on board with using them because they're seeing the inflammatory markers drop so much. And I know so many patients who are maxed out on dosing, but they have no benefit until they start the GLP-1. And then it's like, boom, people are getting their life back with conditions that are so debilitating. So one of the other things that's so interesting too is in the migraine population, which is a population that I used to specialize in. I've had lifelong migraine, and mine have been complicated by really serious equestrian accidents, one of which caused me to lose my hearing on one side. And last summer in Europe, there was a paper presented of a small trial of about 30 or 40 people, predominantly women. And it's very interesting because most trials, especially for pain, are in men and they're not in women. But this particular trial was presented at the European Academy of Neurology, the conference over the summer. And it looked at liraglutide, which is an older generation GLP-1. And it showed that over a 12-week period, people's headache days dropped by 50%. And if you are a patient who has longstanding history of migraine, half of the amount of days is a huge win. And the cool thing is the weight stayed stable in these patients. So we know that the headache relief was not related to weight loss. Again, another application beyond just using these for weight loss specifically. Now, there are so many papers because we have 20 years of data going back to when it came out on market with the first brand, which was Byetta. I actually used it in my patients. It didn't work very well, and patients didn't want to take it because the dosing was a pain. But now we have the GLP-1, we have the dual agonist, and there's the triple agonist, which is still in phase 3 trials. And no, you cannot get that through conventional means yet. But there are papers on inflammation. There are papers that show that it modulates the immune system, inflammatory pathology, inhibits inflammatory signaling. It decreases pro-inflammatory cytokines. It increases anti-inflammatory mediators. It decreases tissue inflammation. And as a whole picture, you're seeing people who have improved insulin sensitivity, improved menstrual regularity. They are having improved wound healing. It works on psoriasis, asthma, pulmonary hypertension. I mean, things that you would never even think of. But that's what's so cool about this is how broad the applications may end up being as more research comes out and as more education, just like we're doing here, to help our colleagues and help patients be empowered to say, wait a second, there might be another option for me. I feel like a lot of providers don't give patients enough justice for trusting their body and understanding there's got to be a better way. I don't want to be on a medication that makes me feel badly. I want to feel better overall. How can I work with my system to promote healing long term? Now, some people want to use GLP-1s indefinitely. Other people want to use them in a short kind of burst, much longer than, say, a prednisone burst, but they want to use them for a short period of time to have improved inflammatory markers and just see how they do. But what I found is a lot of people, once they start them, they really don't want to come off because they feel so much better. Now, one of the other things, and I'm just going to touch on this, especially because of my integrative and functional medicine background, there's a lot of people who have inflammatory conditions, who have autoimmune conditions, autoimmune-like conditions. I have long COVID. GLP-1s have been a lifesaver for me, and we will be talking about that in a future webinar. But there are a lot of people who have kind of undiagnosed rheumatological conditions. Rheumatology can't figure it out. It's kind of we don't know, you've got something. And that is a wonderful opportunity to consider using these GLP-1s in that particular patient population. And GLP-1/GIP specifically tends to do a little bit better than the actual GLP-1 the side effect profile is a little bit better with the dual agonist than the single agonist. But just the thought of expanding the potential applications, just the thought of treating more than just one specific organ or disease process, just the thought of here's something that improves longevity, it decreases inflammation, it resolves insulin sensitivity or resistance. It's just really exciting to be in this new peptide era, as I said today in social media, because we now have options that we didn't have before. When I was doing internal medicine and I saw all of those autoimmune patients and hand patients who I sent to you, Kimberly, probably, I did the best I could for them. I gave them, a prednisone burst and just, okay, let's give you 20 of pred and let's see if we can calm this down. And yes, I hit them hard, but then it was, well, we can't use these long term. So I used the turmeric. I was using every sort of herb and option I could. But what I wasn't really using a lot of at the time, which is something now that a lot of people really know about, is low dose naltrexone, which can be a really wonderful option, and it can be very synergistic with GLP-1. So for those joint pain patients, using that may also be really great. And there's actually a lot of good data coming out now about that, including increasing the dose on that. And also there was some new evidence about using it and taking a 3-day holiday to make sure that patients remain sensitive to it. But in general, the GLP-1s for so many, there's just such a broad application for new ways of using it. And I would encourage patients and clinicians to think outside the box, just like you said, Lori and Kimberly, think and see what else can we use this for? Thinking about the pathways, thinking about what's underneath this, not just saying your knee hurts. Okay, let's just give you a steroid shot. Okay, wait a second, let's back up. What happened 10 years ago to start your knee pain? What's going on at a systemic level? What's happening with your heart disease? What's happening with your hormones? And really taking a step back. Now, not every person has the luxury of spending the time with a patient to be able to do that. And not everybody has the training or inclination or even desire to understand it on a more holistic and integrative level. But that possibility exists. And I feel like sometimes patients are at the forefront of that movement by coming in and saying, hey, I want to know about this, because then it compels clinicians to really kind of dive in. So, and I am hoping that we will be able to talk more about this in the next episode. And we haven't announced the topic yet, but we are going to be still covering things like inflammation, midlife, hormones, which is a big subject. And I am so excited to just keep going. So ladies, it has just been so wonderful to have you here today, and I appreciate your expertise and sharing your experience tonight. I think it's been invaluable for everyone listening and everyone who will listen to the replay, and I just appreciate your time. And for everyone who joined us, thank you so much for being part of this conversation and being interested in peptides and being interested in understanding them more. If you are wanting to start some peptides, please go back to the person who invited you to this call and connect with them, because they can help you. And if you are a clinician who's interested in offering peptides in your practice, right now I'm hearing from my colleagues that many private practices are unable to offer peptides beyond just the brand names, especially for off-label uses, because many pharmacies are not allowing new contracts. So if this is you, please reach out to the person who brought you in for this call, because they would love to help you figure out a way to be able to offer it to your patients, improving access and hopefully improving patient outcomes. So until next time, thank you again, Lori Fitzgibbons and Kimberly Brown. I very much appreciate you being here. Thank you so much, and I hope everyone has a good night. Thank you.